Glenda is a 64-year-old woman who recently underwent a mastectomy. Since her surgery, she's had increasing shoulder pain and restricted movement of her arm. Over the past month, she's had increased pain and stiffness, impacting her quality of life. Her pain is worse at night, leaving her tired during the daytime, and the stiffness is even making it hard for her to dress herself and do other activities. She's wondering if this will get better on its own, or if there's some type of treatment for it. Frozen shoulder, also known as adhesive capsulitis, is thought to be caused by thickening of the connective tissue around the shoulder joint, leading to pain and reduced range of motion. It may be triggered by an injury or surgery and can be associated with certain conditions like diabetes. It's quite common and generally affects people in their 50s and 60s. It generally develops slowly and has 3 phases. In the initial freezing phase, moving your shoulder will be painful and you won't be able to move it as far as before. In the frozen phase, you may have less pain, but more stiffness and difficulty moving your shoulder. In the final thawing phase, your shoulder movement improves. Frozen shoulder generally resolves within 3 years and often gets better on its own. There are a range of treatment options available. We've asked Dr. Raj Carmona to talk about frozen shoulder. Dr. Carmona is a rheumatologist and associate clinical professor of medicine at McMaster University. Well, thank you so much for joining us this morning, Dr. Carmona.
It's a pleasure to be here.
So let's start with the basics. What exactly is frozen shoulder, and what will most people with frozen shoulder experience?
Right. So frozen shoulder, also known as adhesive capsulitis, is a condition where the capsule of the shoulder becomes inflamed. And this can lead to thickening and contraction of the tissues in and around the capsule, which then leads to restriction of movement in all directions. And this is why the term frozen is commonly used, because the patient loses a range of movement in all directions. The condition is generally described as occurring in 3 phases. So there's an initial freezing stage where there is a severe disabling pain. The pain tends to be worse at night, and there's progressive stiffness. And this stage can last anywhere from about 2 to 9 months. And then this can be followed by an intermediate or frozen stage. During this stage, the pain can begin to subside, but there's marked loss of movement, and this can last from about 4 to 12 months. And this can then be followed by a recovery or thawing phase. And in this phase, the range of movement begins to improve. And this phase can last from about 5 to 24 months. So overall, a frozen shoulder can last up to about 3 years in many patients.
And does it tend to recur or come back in the same shoulder or the other shoulder?
So it's unusual for frozen shoulder to recur in the same shoulder, but up to 20% of patients can develop the condition in the opposite shoulder within 5 years.
So, what are some of the things that put a person at risk of developing frozen shoulder? I guess what causes frozen shoulder?
Right. So first of all, frozen shoulder, like many conditions in medicine, can be idiopathic, meaning that there can be no identifiable underlying cause. Frozen shoulder is certainly associated with older age, so it typically affects patients 40 to 65 or older. It's most common in people in their 50s and is absolutely rare to occur in someone who's under 40. Sex seems to play a role in that it's a bit more common in women compared to men. Certainly, shoulder injury can predispose to a frozen shoulder. So, for example, someone who has sustained a fracture of the shoulder, or a rotator cuff injury, or someone who has had a surgery to the shoulder. And in fact, any condition where there is prolonged immobilization of the shoulder can also predispose. So, for example, someone who has had a stroke, someone who has had a surgery like a mastectomy in the patient that you described, and even surgery distant from the shoulder, for example, neurosurgery, where there's prolonged immobilization of the shoulder, can predispose to a frozen shoulder as well. Diabetes is recognized as being a major risk factor. In fact, in many studies, up to 20% of patients or even higher of diabetics can develop a frozen shoulder. And then there are some other systemic diseases that can predispose, for example, an underactive thyroid or hypothyroidism, an overactive thyroid or hyperthyroidism, stroke, some autoimmune and inflammatory diseases, and conditions like Parkinson's disease.
So it sounds like, on the one hand, it is a little bit of a mystery in terms of all of the different things, but lack of movement definitely seems to put you at risk along with age.
Yes, absolutely.
So, how would you actually diagnose a frozen shoulder in the clinic?
Right. So this is often a clinical diagnosis, meaning that the doctor will do an extensive history by asking the patient a bunch of questions to try to figure out what is going on and what the underlying cause might be. Um, and then for this, it's followed by a physical examination. The key finding in frozen shoulder is that there's limitation of movement in all directions, both when the patient tries to move the shoulder themselves or when the doctor tries to move the shoulder for the patient. And usually, imaging is not required. In fact, doing an X-ray in someone with frozen shoulder, usually the result will be normal. It can show some other conditions, for example, underlying osteoarthritis. And advanced imaging, such as ultrasound and MRIs, are generally also not required. But it depends on the clinical condition. If the physician suspects that there's some alternate pathology going on, especially during the early phase of the disorder, an ultrasound or MRI may be ordered during that time.
What are some of the things that might look like frozen shoulder but are not frozen shoulder, or are maybe more worrisome causes?
Well, I mean, certainly, if someone presents with a severe disabling pain of the shoulder, as in that early stage, then you begin to worry about other things. For example, an inflammatory arthritis developing with onset within the shoulder is a possibility. Certainly, injuries. For example, if someone had fallen, you want to make sure that there's no fracture. Someone may end up with prolonged loss of movement with advanced arthritis, for example, osteoarthritis of a glenohumeral joint. But even though there's loss of movement there, that's not usually referred to as a frozen shoulder. So there are a few other things that you might want to consider. And again, like early on, if it's not quite clear, that's where imaging might be helpful. But usually, in most cases, you do not require imaging to make the diagnosis.
So in most cases, the story is pretty suggestive. At what point do most people sort of go to see their doctor about frozen shoulder? Early on or later on?
I well, that's a bit difficult to say. I mean, I think it may depend on the threshold of the patient in terms of how worried they are about the pain that they're having. I think certainly most patients will probably go pretty quickly because that early stage is quite debilitating. It's extremely painful. There's progressive stiffness. The pain is worse at night. It can interrupt sleep, for example. So usually a patient would go to see their doctors early. And then if they don't, then certainly with that subsequent stage where there's loss of movement, I think that should cause concern in most patients and lead them to see their physician.
So, what can be done about this? What are some of the evidence-based treatment options for frozen shoulder?
Right. So the first thing I'll say is that I mean, if you look at most sources of information, you will see that a frozen shoulder can spontaneously improve over about 12 to 18 months. I want to point out here, though, that does not mean that the patient should neglect the condition and do nothing. We know that when you don't have movement in a joint for a prolonged period, that can lead to significant atrophy or loss of muscle around the joint, and that is something that we'll want to prevent. So, in terms of medications, usually an over-the-counter anti-inflammatory can be quite helpful. So, something like ibuprofen or Advil, naproxen, also known as Aleve, those can be helpful in that early stage. Sometimes the doctor may need to prescribe some more potent analgesics because the pain can be quite severe in the beginning.
The initial phase with the pain, using pain relievers and anti-inflammatories may be helpful. When you're saying like the prolonged lack of movement is a problem, are there particular ways, like is physiotherapy something that people would be recommended to do at one of the phases to ensure that there's some kind of movement going on?
Yeah, so absolutely, and that's a vital point. I often tell my patients that physical therapy and range of movement exercises is as important, or probably even more important than any medication that we can prescribe. So I highly recommend that patients see a physical therapist. They'll be taught range of movement exercises, and these should begin as soon as possible. Now, the key here is that the patient needs to commit to doing these exercises diligently to maximize recovery of shoulder joint movement. And then in terms of some other treatment options, so certainly steroid injections has a role. Steroid injections have been shown to reduce pain and help with regaining range of movement in the shoulder. And this is most efficacious if done during the early stage of the disorder. And then there's some other interventions, for example, a joint distension. So this is where the doctor can inject sterile water into the joint capsule to try to stretch that capsule and improve range of movement. There's also the option of having a shoulder manipulation under a general anesthetic. So essentially, the patient is put to sleep so that they would not experience any pain, because the doctor will then forcibly manipulate the shoulder in different directions, again, to try to stretch the capsule of the shoulder and improve the range of movement. And then finally, there's also surgery. Now, this is not commonly done, but it can be considered if there's still significant restriction of movement after 12 months. And in this procedure, which is usually done arthroscopically, instruments are inserted into the shoulder via small incisions around the shoulder, and then the surgeon tries to remove or cut any of the scar tissue and adhesions within the shoulder joint.
For most people, though, it's probably a much more conservative approach with some anti-inflammatories or pain relievers, and making sure that they're following sort of active range of motion exercises or physiotherapy. I'm thinking most people probably don't even go on to require either injections or surgery. Is that fair to say?
Yeah, that's correct. Anti-inflammatories earlier, plus or minus steroid injections, and certainly physical therapy, absolutely important. It's really a small proportion of patients that would need to have a more invasive procedure done.
I'm going to say for a lot of people, though, it's really a long time. You were saying a lot of people might be experiencing the various phases for a year up to 3 years. I imagine people sometimes do get quite frustrated with the change in their level of function.
Absolutely. This can be quite frustrating for the patient. The inability to use the shoulder can significantly impact anyone's function. So it can be quite frustrating. I think reassurance of the patient here is important, and certainly encouraging them to do those range of movement exercises diligently is an absolutely essential part of management.
Can you talk about some of the evidence behind steroid injections in particular?
Sure. So what I would say is that overall the data is limited, but there are a few pieces of research that we can look at. So there was one small trial published in 2016 that looked at 74 patients, and the patients were randomized to receive either oral anti-inflammatory medications or an intra-articular steroid injection, meaning a steroid injection into the joint. And what researchers found is that patients who got the steroid injection had faster pain relief and improvement in the range of movement. However, when they looked at patients at 12 weeks later, there didn't seem to be any difference between the treatment groups. So it appears that steroid injections can be helpful along the way, but in the longer term, doesn't seem to have much of a difference, at least in this small study. Then there was a systematic review and meta-analysis published in 2017. And just to mention that a meta-analysis is a study where researchers combine a bunch of similar studies and look at the combined results. And these studies looked at steroid injections versus no injection versus a sham injection. And a sham injection is where an injection was done, but steroids, in this case, steroids were not injected. In the studies, they used various types of steroids, and the doses also ranged from 20 to 40 milligrams. All patients were also given an exercise program for stretching the shoulders, and then patients were followed up for about 6 months afterwards. And when researchers looked at the studies here in this meta-analysis, they found that there was reduced pain in patients who had steroid injections over a 3 to 6 month period. And there was also a modest improvement in terms of shoulder mobility measures and pain and function scores at 6 months. So again, it seems as though steroid injections here were helpful. And then there was a more recent meta-analysis published in 2020, and in this particular study, they looked at patients with frozen shoulder for less than a year who got steroid injections. And again, the steroid injections were associated with better outcomes. This study also showed that an exercise program provided added benefit. So I think overall, the key message here is that steroid injections can be helpful in reducing pain and improving function, but should be done in the early stage when there is some degree of inflammation going on. Once the patient is in the frozen stage, where there's a restriction of movement and the pain has sort of subsided, then at that point, steroid injections may not be of much benefit. At that point, physical therapy with diligent range of movement exercises would be most helpful.
So, circling back to Glenda, our 64-year-old woman who has the frozen shoulder, what would your approach be with her?
Well, I think the good thing here is that we are catching this patient early. She's only had about 1 month of symptoms. So this is not in that early stage where there may be a significant amount of inflammation, but this is before much scar tissue or adhesions have developed in the shoulder. So at this one, I think certainly starting her on anti-inflammatory medications that would be quite helpful. She can certainly begin with over-the-counter anti-inflammatories, and if that's insufficient, then certainly prescription strength anti-inflammatories would be indicated. And then if these are unhelpful, I think certainly there would be significant benefit from considering a steroid injection given how early this is. And as we mentioned earlier, certainly having her see a physical therapist and beginning range of movement exercises would also be very important.